Okay.
Okay, I am a strong believer in not punishing the punctual, so we will begin. And I'm pleased to introduce Jess Spohn. Am I pronouncing your last name correctly?
Spohn. Close.
Spohn? Okay. Jess is a licensed clinical social worker and addiction counselor, and the clinical director of the Dona County Crisis Triage Center. Jess is also has a master's degree in public health and social work and is pursuing a doctorate right now in social work with an emphasis on social justice. And Jess will be speaking to us today about the work of the center, which is a new resource available to our community. And pleased to have you, and thank you very much for spending your Sunday afternoon with us.
Thank you so much for the invitation. I'm happy to be here. Welcome, everyone. So what I'll do is I will share my screen and we'll get started with the presentation. If you get questions, while we're going through things, throw them in the chat or anything like that. We'll do kind of a Q&A at the end. But I know me personally, if I don't raise my hand or write it down, my questions, then I forget them by the end of the presentation. So we will go ahead and get started. Here we go. All right. So, and then I'm going to move my thing this way. All righty. So the Crisis Triage Center is operated by RI International. And so this is our most recent picture from our leadership retreat last year. And I think you can see I'm down here a little bit right here, and our program director is right over here. It's hard to tell with everybody's masks on, but that's, the state of things, especially with the COVID pandemic. But I wanted to just kind of show, I like this nice little picture of everybody with RI. And RI has been doing this crisis work for over 30 years. So we'll talk today about the No Wrong Door, right? Crisis services in Doña County. And as introduced, I'm the clinical director at the CTC here. We've been open for about a year or so. I think we're about 15 months now that we've been open, and here to serve the community. We're located right next to the detention center, but we're not part of the detention center. And I like to consider the CTC as a mental health ER. So what that means to me is that we are open 24/7, 365, and we're never going to say no, right? When you go to the ER, they don't say, oh, you were here last week, sorry, go somewhere else. They don't say, you don't have insurance, so we're not going to treat you. And they don't say, oh, you're only bleeding like 2 buckets of blood, sorry, that's not bad enough, right? So we are here for the mental health and substance use emergencies. And even, kind of down to, whatever kind of crisis counts as, and we'll get into that. But everyone that we see, we call them our guest, and we host them. So instead of being called a client, a patient, a customer, a consumer, everyone is our guest, and we can hold up to 12 guests at one time in our rooms. We've got, and I'll show you some pictures of the inside as well, but we've got our living room space that if we get a little bit of an overflow, if we, number 12 or, 13, 14 wander in, we'll be able to help them out as well. So we serve individuals that are 18 and over. So we can't have any minors in our facility based on our license. And that includes any minors that's accompanied by a guardian, like a parent or a guardian. So no kiddos at all. Anybody that's experiencing a mental health or substance use crisis, whatever that means to them, right? I'm not here to decide what a crisis is to you. So that could be someone that's feeling depressed. That could be someone that's feeling suicidal. It could be someone that's hearing voices. It could be somebody that's like, school's got me on edge and I don't know really what to do right now. Or the person that says, I just don't feel right. I don't know what I'm feeling, but I don't feel right. It could be someone that is actively using some, alcohol or other types of substances. whether they want to quit or not, or someone that's already quit and wants to stay sober, but they don't think they can do so effectively on their own because of whatever's going on in their life, their environment, other triggers, things like that. So we take a very wide variety of individuals, but one of the key parts is that we're voluntary. So they have to want to receive these services and be able to sign for the consent forms. So we can't hold anybody there against their will. It's different than like an inpatient hospitalization. So if someone comes in and says, yes, I want to receive services, and 2 hours later, they're like, you know what, not feeling the vibe, want to go. We say, all right, let's, we kind of try to re-engage them and see if we can do anything differently. But if they're really adamant on leaving and they're not a severe danger to themselves or others, then they're able to go. So a little lobby right there. So with our staff, all of our shifts have a registered nurse, a licensed mental health provider, also known as a therapist or a clinician, and our certified peer support specialists. Our night shifts have behavioral health technicians as well, which are kind of a go between a peer support and a clinician. We have psychiatric providers available on telehealth as well. And we have 24/7 Spanish speaking coverage on site. So at least one staff member per shift is Spanish speaking. And we've got a couple people that are certified translators for Spanish language. A peer support specialist, in case you're not aware, is somebody that has lived experience in recovery themselves from mental health or substance use. And so with our staff, they're all certified by the state of New Mexico through OPRI, which is the Office of Peer Recovery and Engagement. Peer support are some of my, our peer specialists are some of my favorite types of, practitioners, because their entire job really is to say, hey, I've got some experience, like I've lived through it, I'm in recovery, you can too. And they're there really to model hope, right? And instill some of those recovery values and show that recovery is possible for anybody at any point in time, whether it's mental health or substance use or both. But all of our peer specialists have at least 3 years in recovery so that they've got that, all that recovery kind of under their belt, that they can really help, individuals, see that sustained recovery is possible. And I was mentioning to Dave earlier that I'm in recovery myself. And so it's really cool to be a clinical director and be a clinician, but also kind of have that hybrid into the peer support realm as well. And we're also expanding our mobile crisis. And so we just hired a mobile crisis director. And then we've got a team that's going to be doing the front end mobile crisis. And, we're kind of working on the back end as well. I'll get into that kind of closer to the end, but just to kind of give you a little taste at the beginning. So here's some of our staff back here. And then this is, one view of our living room. This is kind of our nurses station. We call it the island over here. But as you can see, we've got some tables, and there's a better picture here and a little bit of like our retreat area. So what do we do with the CTC? The guests are able to stay with us for up to 24 hours at a time. And what they do, I always like to mention, kind of the process. They'll get changed, they'll sign some paperwork, they'll get changed into some scrubs, which are cloth scrubs that I really think are more like pajamas, right? They're wanded for safety. Their belongings are all placed in a locker for the duration of their stay while they're with us. They'll get a nursing assessment, they'll get a clinician assessment, they'll be able to see a psychiatric provider if they'd like to. And if together the provider and the guest have decided that medication would be the best route, then we can start them on medications as well. We've got the peer first, peer last model, which means that the very first person that they're going to see when they walk in is a peer support specialist that's going to say, hey, welcome in, let's talk about what's going on. And they're going to be the last person that they see out the door saying, thank you so much. We hope that you're feeling better. If you ever need us again, you know where to find us. We can come get you, or, you can come on in. Our guests get 3 hot meals a day. We've got showers. We've got laundry. That's part of the reason why we change people into scrubs, so we can wash your clothes. I think I'm in, showers, snacks. We've got lots of activities, that people can do either by themselves if they need a little bit of alone time or with one of our peer specialists. And then we do like a comprehensive discharge plan that starts right at the beginning. So when a guest walks in, right, they're going to tell us kind of what they're here for, what the nature of their crisis is, what's going on. And our wheels are already turning to be able to get those individuals connected to the care that they need, whether that's like a higher level of care. Maybe they do need to go to see a medical provider on an emergency basis, or maybe they need to go to inpatient mental health care. Or, and we can get them transferred over there. We start that process. Or maybe they just needed a little bit of extra support until they see their therapist in a couple of days and they're already connected, or they need connected to a new therapist or to medicated assisted treatment services. But we partner very closely with a lot of community providers. So that, our guests can get the quickest and most comprehensive access to community resources that'll really help them stabilize and continue to kind of maintain that sense of stability when they go back home. I like this messages of hope wall that we have. We have sticky notes up there that have got all kinds of great things on there. And I encourage some of our guests too, that once they're getting closer to leaving, hey, and I'll give them a couple sticky notes and what would be useful for you when you first came in here? What do you want someone else to see? And then so we get lots of really great stuff. Sometimes there's pictures, sometimes it's stickers, it's great. Our main thing with the crisis center is that we say yes. We operate under the Crisis Now model. And the Crisis Now model and the no wrong door policy. The Crisis Now model says that individuals that need care now should be able to receive care now. Right. So often we think about mental health in town or, just anywhere, but, especially in Las Cruces in our area, that, okay, like, hey, I need meds, right? Like, I just don't feel right. And I think I need medication. Okay, well, you're going to have to see this person and then they're going to have to do a referral. And then it'll probably be like 2-3 months, maybe, before you can start getting on meds, right? How unfortunate is that? And then a lot of people end up in the ER. The ER is not the best place for people who are experiencing a kind of crisis for mental health, and that can actually make things worse at times. And so with the Crisis Now model, we're going to say yes. So as long as the guest says yes to us and they're over 18, we're going to welcome them in every time that they come, whether they come once or, they come 35, 50 million times. We're going to treat them, with kindness and respect every time that they arrive at our door. And that no wrong door policy basically means that we are the right place for the right reason every time that they need assistance. So anybody can come through anytime, day or night. We're open 24/7. We do enrollments 24/7, without being turned away. And so with many of the hospitals, the inpatient psychiatric care units, you have to meet certain levels of criteria. You have to be, a certain level of suicidal or wanting to hurt other people or detoxing from specific substances, but not other ones. Or if you're trying to go to an outpatient clinic and you come and you are under the influence, they'll turn you away, right? So no one is going to be too drunk, too high, not depressed enough. And we also don't need medical clearance. So they don't have to go to the doctor or go to the emergency room before coming to see us. That's why we have our nurse on site who can do a medical triage and see if they do need immediate medical care that we can't provide. And then we usually get them transferred over to the hospital in those cases. And we have a strong relationships with a lot of the hospitals in town. So then they also we'll keep in contact, and then they'll call us when they're done and say, hey, okay, they're good to go. And we'll pick them up or they'll send them, and then they'll be able to return to the level of care they were originally intending. So this picture here is part of our living room, right? Part of our retreat area. So, as you can see, we have nice, bright, warm, welcoming colors and environments. RI International actually created the living room model in 2002. And so this is supposed to be, compared to like a hospital environment, a lot more comforting, right? And kind of natural feeling than, what you may seem, so that you'll feel, feel more comfortable, right, getting care and welcomed. So for referrals, we don't technically require referrals. That's part of the Crisis Now model. So there's no barriers in like waiting on me to tell you it's okay to bring the person by. We don't have any insurance prior authorizations. I always mention that we don't check for warrants or immigration status because we are next to the detention center and people can get a little bit uneasy about that. We're here to help. We're not here to make things worse, right? So we're not going to run you through a system. We're not going to call the detention center or ICE or, anybody. We actually don't allow them in our facility. We are one of, I don't know what it's called now, but we're basically like a safe facility. So if someone came in, like they can't get deported for getting help. We accept all insurances. We get paid through Medicaid, but if someone has a different level of insurance or no insurance at all, regardless of whatever kind of insurance coverage status you have, they're never going to have an out-of-pocket cost. So it's completely free to the person, however many times that they need our services. So I think that that's something that really sets us apart from a lot of other places in town where you have to do a copay or meet your deductible, or you get a surprise bill, for getting services, even if you were at the ER for, like an hour and, now you got to pay thousands of dollars for this one blood test they did, right? Like that's not how we operate. And people can get to us through a variety of ways. They can come as a walk-in on their own. Literally, we have people that walk in off the street, or they drive themselves. A loved one or maybe a case manager can bring them. We have a great relationship with the detention center. And we actually, our peer specialists go into the detention center and talk to people, about 2 weeks to a month or so before their plan to be released, to kind of include that into their discharge planning. But we also go talk to people as they're being released, and say, hey, the service is available. If you're interested, come walk right on over with us. So, there's kind of that social way to get here, or people can come through first responders. So at RI International as a whole, across all, I think like 10 states or so, typically besides New Mexico, typically about 85% of the individuals that go into an RI facility come in the back of a police car. Wow. With us, it's a little different. Because we don't take, I think partially because we don't take involuntary referrals, and most of the other facilities do, like more similar to a hospital. But, we've got about 15 to 20% of the individuals that come to our facilities come in a police car with the police officer. And so we do that kind of jail diversion, in a sense, that instead of these people being taken to jail, they get taken over to us. And we also do emergency room diversion. So instead of the officer taking someone to the ER for them to sit in a hallway and maybe probably not even get care, because I don't know about you, but if I'm in crisis and I'm really not feeling great, I don't know how long I'm going to want to sit and wait in a lobby, in a waiting room, or in this bed that nobody's paying attention to me. Right. So, and our EDs in town, our emergency departments in town will call us and say, hey, we've got somebody that's more appropriate for the crisis center. Because they know, we all know that our ERs are great, right? They're great for medical. They're not built for psychiatric care. And so with the ER diversion, we're helping get people to the appropriate level of care. Also, fire department can bring us people, ambulance can bring us people. So if they're going out and responding in the community, they can choose to bring to the crisis center instead of to the hospital. And we do have right now, it's a limited availability. And like I said, we're expanding to pick up guests in the community. So maybe there's somebody that is interested in receiving services, but they don't have any other way to get there. And we don't really want to call the police to go get them. Anywhere in the county, we can go and pick them up. So, all the way down to Sunland Park, up to Hatch, into Mesilla, of course, Las Cruces and Doña. And pretty much over to White Sands. So we've got a big hour radius of people that we're able to serve. And so one of the ways, that we're integrated is with 988. I don't know how many of you have heard about 988, but it is a national 3-digit number that went into effect in July this year. So it's very, very, very new. But you can call, you can text, or you can go online and chat with 988. And it's like the mental health 911. Right. So it's if you're feeling depressed or you're having a panic attack or you're under the influence, instead of calling 911 and having a police officer respond to your door, you can call 988 and you're directly connected to a crisis counselor. And that's anytime, day or night. It is confidential and anonymous to the point, depending on how much information you provide to the call taker. And so really 988 is federal legislation that was passed in 2020 and finally came about and was implemented this summer. And so this is in any state, anywhere you're at. If you call or text 988, you're going to get a crisis counselor. And the big goal is to destigmatize people getting help for mental health. And it also reduces law enforcement presence in mental health cases, right? It also reduces healthcare spending as well, because people aren't going, to the ER. Right now in New Mexico, I think about 85 to 90% of the calls that go to 988 centers in New Mexico are resolved on the phone. Right. So that's basically 9 out of 10 people that call that don't need any additional help, that are good to go, after they finish talking with a crisis counselor. And then, 1 to 1.5 of the individuals maybe then need a mobile crisis team or a law enforcement, response if there is a public safety issue, if they have a weapon and are planning on using it, or need to go to a crisis facility. And so the way that we do mobile crisis at the CTC aligns with that Crisis Now response model. The Crisis Now response model says that it should be a clinician and a peer support specialist that go and respond. So I wanted to kind of talk about, the mobile crisis, and 988 Crisis Now models in general, and kind of compare it to what we've traditionally seen. Right. So what we're used to, right? You call somewhere, which is typically 911. And then you say you need help. So they send somebody out, which is, usually a police officer. And then if you can't resolve it right there, then they take you somewhere, which is usually the hospital or jail. With this Crisis Now mobile crisis response, you call somewhere. And so that's 988, right? Or your crisis line in your state. And you talk to somebody. If you need additional services, then a mobile crisis team would be, theoretically dispatched. Of course, we know that there's specific challenges, in rural and frontier areas. So that may be a co-responder model that's like a law enforcement or other first responder with a clinician, or, just kind of depending on the community makeup. But typically it'll be a mobile crisis team that goes out that's made up of at least a clinician, maybe a peer specialist. And then if they can't resolve it there, instead of going to the hospital or going to jail, then they bring you to a crisis receiving facility. And so, of course, that's going to look different in other communities. But here in Las Cruces, that's the CTC, the Crisis Triage Center. So that, completely for so many people is going to remove the necessity of law enforcement. So we don't like have a police officer go clear the scene first. We just go, and it's triaged on the phone. And there's definitely an element of safety that's always considered beforehand. If you call 988 and you have a weapon, or, there's some other level of, very high natured, unsafe behavior going on, then a law enforcement officer may come out. But mobile crisis would be kind of there waiting to make sure everything's okay. And then they're right there with them. So, in most cases, it'll be a mental health response for a mental health crisis. And this is like the national best practice to do it this way. So that's pretty much what I have. So I put our address here. I put our phone number here, and then our fax number in case you ever need it. We've got our Courage and Hope hallways and our wings in there. So I put our site director's email as well as my email address on here. I'll leave it up just for like another minute or so. And then if you want, I can just kind of take it down or I can put it in the chat if you'd like. I can put all that in the chat instead, and then we can just have a great conversation on any questions or thoughts that you have.
Jess, would you mind sending me a copy of your slides, then I can make them available to anybody, the whole set, to anybody who has an interest?
I sure will. I'll do that as soon as we get off.
Okay, great. Thank you. Well, thank you so much for your presentation. And so we'll open the floor now to questions and comments. And Susan, did I see your hand go up?
I have a question, but Dave, I would like a copy of the information that you get, because I'm on the caring committee, and I think it would be very helpful if I let them know about this service. A couple questions for you, Jess. One is, how long can a person stay at your triage facility?
They can stay with us for up to 24 hours at a time. So it's very, very short term. You know, we're kind of like we're kind of like a hub. We don't provide like the services, so we're not like an outpatient clinic, but we get them connected, right? To, I think of like Tinker Toys, right? The ones that like has the wheels and you put all the little spokes and stuff in them. You know, we're the little wheel, and then we're getting them connected to the best place for them to go after us.
And I know you said that you get Medicaid funding and you use insurance. What funding are you getting that is for people who are uninsured?
So
how do you?
Sure. We have, like you were mentioning, we get funding through Medicaid. We're also partially funded through the county, through Doña County. So we get money from the county indigent fund, so we can bill for that. And then we just finally secured a contract with Falling Colors to kind of, which is like the statewide kind of indigent fund, to cover everybody that has inadequate insurance, which it seems a little kind of counterintuitive, because say, for example, you're like me and you get your insurance through your employer. And you have, commercial health insurance. Commercial health insurance doesn't cover crisis care in New Mexico. Neither does Medicare, and neither does the VA. And so Medicaid is actually the only health insurance, like MCO, that covers crisis care. So your insurance, this is like a whole like piece for lobbying and legislative reform, but your insurance, basically, if you have, what people consider to be the good, right, insurance, is actually would prefer right now to, in practice, is paying for you to spend thousands and thousands of dollars in the ER instead of, the crisis center, which is, which costs, our cost for being 24 hours at the crisis center is less than, even like a couple hours at the ER. So, that's a whole separate issue, but we've got money from the county, and we have some state grant funding as well as the Falling Colors.
I have some more questions, but I'm sure other people do too. So I'll stop and see if there's time.
Dave Rice has his hand up, and then we'll cycle back to you, Susan. So
okay,
stay tuned. So Dave.
Okay, yeah. Thank you very much, Jess. Where we crossed paths was in looking at the unhoused or the homeless. What fraction of the people that you end up caring for are homeless, so that if you discharge them, they go back literally onto the street?
I don't have a specific number of the guests that we see that are experiencing housing instability, but I know it's a big number. And so what we do is we try to get them connected to either the Gospel Rescue Mission or the Community of Hope. And I know sometimes that can also be a big process, because with the Gospel Rescue Mission, it can be a little bit difficult, because they need either a negative COVID test or their vaccination records and an ID, which, for many people experiencing housing instability, they don't always have access to these types of documents. But and Community of Hope has a pretty long wait list. So some of the individuals do go back out on the street. but we try to get them connected with other resources. So maybe we're trying to get them they have severe mental illness and we're trying to get them connected to an ACT team, and the ACT team can help with the housing. Or if it's someone that's experienced a sexual assault recently, we have La Piñon come out and do an assessment and evaluation, see what they can do for the individual. And sometimes that's emergency temporary housing. We'll do an intake with La Casa for domestic violence survivors. There's a couple of different funds in town that are very limited, but sometimes they have at least some type of funding, emergency housing funding to get somebody at least somewhere to stay for the night until they go over here. Or some of the, but we do see a lot of the individuals that are experiencing housing instability also, have a higher level of mental health crisis, and maybe they do need the inpatient care, which, can at least give them somewhere safe to be for a little while, we're trying to get everything else worked out.
Okay. Thank you. Now, my second question was, you'd mentioned that the care that you give or often is available is not supported by the VA, but in spite of that, I mean, the veterans suffer from a much elevated level of suicide and drug abuse, is my understanding, compared to the average person. I found that to be strange. Yes.
So, it's really interesting with insurance, and we do have let me clarify, we do have a relationship with the VAs, and they send people over to us. It's just that the TRICARE doesn't cover it. I think because crisis care centers, like crisis receiving facilities, crisis triage centers, are so new that not a lot of places know what to do. I know when we were starting up the CTC in town, we were having a heck of a time trying to get licensed through the Department of Health and the pharmacy boards, because they were like, well, you're not inpatient, you're not outpatient, what are you? Right? There wasn't even a classification. So the fact that I think it's been like 2 years maybe that crisis care has been covered under Medicaid, and there weren't any crisis relief facilities in the state, but now there's a couple other ones in the state of a different caliber than ours. But yeah, I mean, we try to reach out to a lot of different places in the community, including veterans and military services, because you're right, there is a higher instance of depression and suicide and PTSD and housing instability for our active duty service members and our veterans.
Thank you, Jess.
Jess, I have a question, or sort of a nested series of questions, and I was surprised to hear that by virtue of the licensing arrangement at your facility, that you're unable to provide services to those under the age of 18. And did I hear you correctly when you said that even if a parent were to come in with a child, or that you cannot provide them services? Did I hear that correctly? That
is correct. Yeah, we can't have any minors in our facility, which is, it's tough. Because kiddos need the service as much, sometimes more than the adults do. We just don't have a way to separate the adults from the kids, and we want to make sure everybody is safe, right? Mm-hmm. And you don't want a 12-year-old or a 16-year-old around, a lot of adults in that vulnerable populations, abound. So there really is, especially in our area, a lack of services for, especially for crisis care for youth and adolescents. But we connect, we'll get calls and we'll try to connect people, or, and I know it's been hard too, because we'll have some people say, well, I'm a single parent and I need help, but I don't have anywhere to leave my kiddo. So then we're trying to game plan and see, where can we have the kiddo be for a couple hours. So that's something that we've done, is for the parents that need assistance. Hey, while your kid's in school, come on over. Mm-hmm. Right. And we've had parents that'll come, they'll drop their kid off at school, they've come over, and then they discharge in time to go pick up their kid from school. So at least they were able to get services for a little bit, which is helpful. But we rely a lot on FYI Plus to kind of help out. And I think La Clinica has a children's services as well, but FYI Plus is spectrum of all types of services that they can help provide.
Okay, well, that was going to be my next question. So I was going to say, a 16-year-old is in conflict with, his or her guardians or parents, gets kicked out of the house and knows about your facility somehow and walks in the door. What do you do at that point?
So far, we haven't had that happen yet. So, but it's great critical thinking. We may, depending on what time it is, we may call FYI Plus and see if they have space at my friend's place, which is their shelter, for their youth shelter. Not that we want to involve law enforcement a lot of time, but it is. I think in New Mexico, you're not allowed to ban a minor from. Basically, like a parent, it's not legal to kick your kid out of the house. And so, we may have to involve CYFD and make a CPS report and all those kinds of things to try to get resources for this kiddo. They can, anybody of any age can always call 988, call or chat with 988. And then CYFD, I don't have the number off the top of my head, but CYFD also has kind of like a text chat line that initially was intended for kiddos to be able to kind of report if they were experiencing neglect or abuse from their parents, but it's expanded to being mental health crisis services. I guess sometimes they get phone calls like, hey, can you help me with this math problem? So it's kind of expanded. It's called, I think it's NM Talk, TALK. So that's another resource as well, helping somebody that's out, that's been kicked out of the house. We don't really have a lot that we can do with that, but at least if they're still, housed somewhere safe, then they can, try any of the hotlines.
Okay, thank you. Charlie Welch.
Yeah, I'm curious. I'm sure you have a great effect on the more docile elements of society. Is there any, do you know if you have an impact on the more violent types who might, in other words, are you affecting the safety of the community?
That's a great question. I don't know if I have a full answer for that. I'd like to say yes, because we're getting, because we're getting people connected to care, right? And when you feel better, you're able to do better, and we are working with individuals that maybe don't quite need to be involved in the justice system, that sometimes would have to go to jail. And so that's also helping, keep people able to be employed, right? Because we know that there's such a heavy stigma around once you've been incarcerated, in trying to gain employment and keep your housing and all those kinds of things. And so for someone to be able to come and get temporary services with us and then get connected into the community, my opinion, my perception is that would just kind of have a ripple effect into the well-being of the community as a whole. We're also giving law enforcement officers, public safety individuals more time to address whatever kind of public safety issues are going on, instead of having to sit with a person. Because if a police officer takes somebody to the ER, they have to sit with them until they get evaluated. And that pulls that officer, let's say, off the street for 2, 3, 4, 5, 6 hours. At times. And so by being able to bring someone to the crisis center, or if individuals already know ahead of time, hey, I can come over here, then that keeps that that specific officer, on their shift out in the community, able to respond to car crashes and, whatever else is going on. The other way that I could see it impacting as a whole is the individuals that come to see us when they don't feel safe, then have somewhere to go and don't make maybe some unhealthy choices in their life, right? If they're feeling like relapsing and they come to us, and then for the next 24 hours at least that, they're sober, while they're, however long they're with us, then that could by proxy kind of reduce crime, right? Related to individuals that are maybe shoplifting or, burglary or any of that kind of stuff while they're intoxicated or high. Not to say that, all, violent crimes are by people with mental health or substance use issues, but we definitely do see, the combination of that and what people feel like they need to do to survive. So if they feel like they have a sense of safety somewhere that they can go, that they know they can get the help that they need, even on a temporary basis, I think that contributes, personally, I think that contributes to public safety and well-being.
Thank you.
Great, thanks.
Susan, we'll come back to you and then to Dave Rice again. So,
Okay. What in the last, I know you've only been open since July, but let's say in September and October, what was your daily census approximately?
Yes, so we've been open about 15 months.
Oh,
And
okay. So you've been open longer than I thought.
Yeah, sorry,
Okay.
last July or last
Okay.
June, July. I think our
Okay,
first guest
so-
was June 21st, basically last July. Anyway,
Okay.
we've served over 1,000. We've had over 1,000 people walk through our door,
Uh-huh.
which our daily census right now, I think in like these kind of months kind of go up and down a little bit because during the holidays, usually it, just mental health census, in general decreases. But also as it's, like we had a couple of really cold days, so we had a lot of more people coming through. But our average census is about 4 to 5 a day that we see. And, even with this 4 people a day, we can host, like 2 times that, 3 times that, we have up to 12. And so I really like to do these presentations to see if we can help get some more people through our doors.
Right. And then how about your frequent flyer in terms of how, people rotating in and out? And do you have a lot of people who end up coming back and needing the service again?
Yes, I love this question. So first, I use the term friendly face. We use the term friendly face at the Crisis Center.
Okay.
I've worked in hospitals and all this kind of stuff. And just personally, the word frequent flyer makes my skin crawl because I feel like it just is not very like trauma responsive and all that. But it's kind of the word that we all know. Yeah, so we're shifting it to friendly face.
Okay.
And so we do have a lot of, friendly faces or returning guests. And for me personally, and, just kind of with the philosophy of RI, we see that as a success, right? Because it's a strength and it's hard to ask for help. And it's a strength to return, to still say, you know what, I still need some more help. It's not, we do see it, but we don't see it as often, people that are coming in like just for shelter. Their crisis is that they're, housing unstable. Usually there's something else that's going along with it, right? Maybe they were kicked out of their apartment, and they were on the street last night and they experienced some kind of assault and they don't feel safe, right? Or they want to come in and they're experiencing housing stability, and they relapsed, right? Or they're trying not to relapse. And so I think that with our returning guests, we mostly see individuals that have some kind of substance use concern that maybe are not quite ready for treatment yet, but they know that they can't keep going at the rate that they're at. So even for today, like today is the day I'm going to be sober for these next, 6, 10, 15 hours or so, somewhere to stay the night. But I definitely see it as a success. I actually just looked at some of these numbers, and for the month of October, 85% of our guests were like individual, like new people basically. So which was really cool. So about 15% were somebody that had either that month or sometime before had been with us before. And, but like I was saying, these numbers really kind of shift because in the first quarter of this year for us, that's July, August, September, about 60% of individuals were unique, right? Brand new to us. And then 30% were people that had returned. And, that 30% could be somebody that just came back once. It could be somebody that came in, September 2021 and now returned. It could be someone that came 16 times in the month. and kind of taking up that space. So, yeah.
Well, I think I have to say, I think you have a wonderful, wonderful program. I'm a retired social worker, and so I'm particularly interested in your program, and I'm really impressed with your model. It's very positive, a very positive model. So thank you so much.
Of course.
Okay, we'll go back to Dave Rice and then I'll come to you, VJ.
Okay.
You're muted, Dave.
Thank you, Dave. One of the incidents here in town involved a person who was undergoing a crisis due to senile dementia. And do you see very many people who are, or their family brings in someone who is struggling with dementia, for example? And that brings me to the other point. Can a third party, like somebody shows up at church and says, and you look at them and say, you need help. If they're willing, can a non-related person refer?
Yes. So I'm going to answer that part first, and then I'll get to the dementia aspect of the question. But anybody can refer anybody. So
Okay.
it's all about the voluntary kind of nature, right? So if you call us and say, hey, I've got this person that like needs to get out of here, we can come and say, hey, we've got the crisis center, we'd love to host you, we can offer you this and this and that, a nice hot meal and a shower and somewhere to sleep and somebody to talk to. And if they're like, oh heck no, I don't want any of that, then we'll give them the information and say, well, if you change your mind, give us a call, stop by, have someone else help you call, etc. So we can't make anybody come with us, even though sometimes we really want to, right? Because like, I know, like everybody knows, in this vicinity that you need this help, but you're just quite maybe not ready or in the mental state to be able to be willing, and able to accept the help. But yeah, so definitely, you have someone show up at the church, or you're at Walmart and you're like, this person seems to be struggling, and hi, I know somewhere that can help you. I pulled over on the side of the street like 2 weeks ago. There was a woman that was just like laying in the middle of the road. And I was like, hey, like it's not quite safe in the middle of the road to be laying here. Come over here with me. And so she came onto the side of the road, and a police officer showed up, and I was like, I got this, hold on. And she was like, I just don't know what to do with my life anymore. And I'm like, hey, we got the crisis center, and so I called, and our team came and picked her up and took her over, right? It's anybody can refer anybody, that you think may need some help. Or if you, as the church community get a call from someone else, it's like, hey, and it's kind of third, fourth degree removed down the line, offer the information, have them give us a call, and we'll see what we can do to either, have them bring them in, or if we need to go out there, if they don't have any other way to get to us, we're happy to go out and bring somebody in.
Thank you.
Yes, of course. And then, we've seen like a handful of individuals that, maybe have early onset dementia, or, have some type of, issue in that area. We don't see it too often. It can kind of walk a fine line, because they do have to understand the consent forms to be able to sign, right? So we want to make sure that this person does have that fully informed consent, and it's not like some, but we've had, individuals that like parents of, older adult children that maybe have some type of developmental disability, that all of them are experiencing a tough time, right? And so they kind of we've had somebody like dropped off, kind of the crisis was that they weren't getting along with the parents, and the parents were kind of like, I've had it right now. And so we provided, in essence, sort of a respite care, which, for, everybody was a win-win situation. They got to get out of the house. The parents got, a minute to themselves. And this person, got connected to some different levels of resources and had somebody else to talk to and talk their ear off. They were talking their ear off about like dinosaurs and rock and roll and all this kind of great stuff. Right. So we have, had a couple of individuals that we've tried to refer to like independent or assisted living facilities. Since we're so short term, we really can't always see that all the way through, but we can get the process started for sure if that's something that this person may benefit from.
Great. VJ.
Well, I think I heard Jess, you say that you don't ask them if they have had the coronavirus shot or flu shot or anything, but if they have not had, if you don't ask them if they haven't had the shots and they're carrying the viruses, then how do you protect yourselves? Or why, what are the regulations? Can you give them shots?
Great question. So we do have a COVID-19 screening form similar to like other medical facilities, right? Like, do you have a fever? Do you have a cough? Do you have, all of these kinds of things, have you got your shot? We don't require the records, right, in order to be able to receive services. But we do kind of ask, and we've got like a COVID-19 kind of policy thing that people sign when they first come in. It's part of the consent forms. We ourselves can't give the shots since we're not a medical facility. We don't have those available. We have a couple of the COVID tests on hand that if someone does start showing symptoms, we can test them and see if they need a different level of care and, and of services. We've had a couple people that have been COVID positive that came through, and we all really, upped our game on the PPE, making sure everybody had the N95 masks and the gowns on, and that person just kind of unfortunately had to isolate in their room a little bit, but at least they were in a safe location and they had the staff to continue to kind of check in on them. They didn't end up having to go to the hospital. I think one of them did due to like the oxygen levels, but then we were able to get them transferred immediately via ambulance to receive the medical care that they needed. I don't know if that answered your question.
Yeah, it does. Thank you.
Great.
Jess, how do people find out about the services that you offer? And I echo what Susan said. This sounds like a wonderful resource for our community. But how do we get the word out so that people know that if they're in this situation, that you're a resource that they might be able to avail themselves of?
I think the thing that has worked by far the best is word of mouth. You know how, Las Cruces is such a close-knit community, and, you're going to ask your tia or your neighbor or your mom or your spouse, like, hey, have you heard about this place? Or do you know where I can go for here? Right. Even before we go to Google. And so really, I love doing these presentations, I'll say it over and over again, because I can get the word out to a couple people who can then kind of share, right, along the lines, and everyone that's informed that knows about this and can promote it. You can, if you like Google search like crisis centers or like I need mental health help or whatever, where the CTC will come up. I'm working on a Google ad right now to hopefully like actually have our info pop up. But unfortunately, we don't have like a site specific like Facebook or social media page or anything like that. And the county website has a little bit about us, but we're trying to see what we can do to make it a little bit more prominent and easy to find, because I had a hard time trying to find it. And if I have a hard time and I work there and I know what to look for, right? Yeah. So we're trying to see kind of what we can do for our marketing. We're on Google Maps. I have that I will also send you along with the PowerPoint, some kind of digital versions of our flyers. And then if anybody is interested, I don't know if we're waiting, I think, on order for like business card size, but we've got some kind of like bookmark size brochures that are in English and Spanish, one side and the other side, that we're happy to drop off in person for you all to give out to whoever and wherever. I keep a stack in my car, and like the individuals that have the signs on the side of the road that are asking, you're saying I need help or I need money or anything helps, thanks. Like I'll talk and I'll say, hey, have you heard about the Crisis Center in here? And sometimes they're like, oh yeah. And, or I'll see somebody that'll be like, I was there last week. And I was like, okay, thanks. We're still here for you if you need us. Right. Or it'll be somebody that, had never heard about it. And if you have access to a phone, you can call, or if you don't, would you like me to pull over and I can call for you if you want to go? So I've done that on a couple occasions, but it's really any way that you see fit, to kind of spread the word, or, if you have like a bulletin, during service or something that you can put it on the bottom that it's a resource, or, we've had a lot of different agencies do a lot of creative kinds of things, like some of the local mental health clinics will automatically add us into their safety plans and discharge paperworks and things like that.
Well, and I'm sure that Susan will get the word out to our church's care team about the availability of this resource. So are there any further questions? We have time for maybe just one. Jack, go ahead.
Yeah, just because first, Jessica, thank you so much. Would you give the telephone number one more time, please?
I sure will. So let me also put it in the chat, and then I'll send the PowerPoint, but it's 575-449-8159.
Thank you.
And
Jack, I'll forward excuse me, Jess, I apologize for talking over you. I'll forward you a copy of the slides too when I get them.
Okay.
So thank you.
yeah,
Go ahead,
and that
Jess.
phone number rings 24/7 on 4 or 5 different phones. So somebody will always answer, anytime you call, day or night. Okay, well, Jess, thank you so much. This was, really enjoyed your presentation, and I am, as I said earlier, I am so impressed with the availability of this type of resource in our community, and I can see why people would want to be a friendly face to you. Well, thank you. We're here to help out the community any way that we can, do something different, give people a different type of experience, and make sure that we're contributing to the well-being of Las Cruces and the surrounding areas. So any questions, please, I'll send the slides and I'll send the brochures. Please feel free to reach out. We're happy to help and answer questions. And do you think this person should come, or what could I do in this situation? We're happy to do that as well. Okay, great.
Thank you, Jess.
Okay, yes. Yeah, thank you very much. So, okay, next week, folks, we're going to hear from our very own James Caulfield. He's going to provide us with resources that will enable us to get a better handle on what our individual households' impact on the environment is in terms of our carbon footprint and what we might be able to do about them. And then also to let you know, as Susan West asked the question earlier about what our plans are for the future of the roundtable and timing and things of that sort. And I can tell you that is something that is being discussed and will continue to be discussed, and we'll see after the new year what's in store. So at any rate, thank you for coming. Thank you again, Jess, and look forward to seeing you all next week.
Thank you. Have a great day.
Thank you, Dave and Charlie.
Thank you.